Could some adults aged 60 years or older successfully discontinue levothyroxine treatment? What's a more cost-effective goal for lowering lipids, using an apolipoprotein B target or using LDL or non-HDL cholesterol? What are the risks for colorectal cancer and all-cause mortality for adults 75 and older? This and much more on today's JAMA Editor's Summary. Hello and welcome to our listeners all around the world. Today is Friday, April 10th, 2026. I'm JAMA Deputy Editor Dr. Linda Brubaker, sitting in for Dr. Kirsten Bibbins-Domingo, the Editor-in-Chief of JAMA and the JAMA Network. Today I'm joined by JAMA Deputy Editor Dr. Preeti Malani. Hey, Preeti.
Hi, Linda. Levothyroxine, the preferred treatment for hypothyroidism, is one of the most commonly prescribed medications in the world. Dr. Ravensburg and colleagues assessed whether a portion of adults aged 60 and older could safely stop taking levothyroxine and still keep their thyroid function in an acceptable range. In this prospective open-label observational study, 370 community-dwelling adults who were at least 60 years old were recruited from general practice sites in the Netherlands. Participants had been on a stable dose of levothyroxine, less than or equal to 150 micrograms per day, for at least a year and had mildly elevated or normal TSH levels. The study gradually tapered each patient's dose, with regular checks on thyroid labs and clinical symptoms over the following year. The primary outcome was the proportion of participants who discontinued levothyroxine and had both a thyrotropin level of less than 10 milli-international units per liter and a free thyroxine level within the reference range at 1 year after the start of discontinuation. The investigators found that nearly 26% of patients were able to stop levothyroxine entirely, with their thyroid labs still in an adequate range 1 year later. Among those individuals on lower doses of levothyroxine, 50 micrograms daily or less, nearly two-thirds managed a successful withdrawal. Importantly, patients' thyroid-related quality of life remained stable, regardless of whether they stayed off of levothyroxine or not.
That's a really great deprescribing opportunity that clinicians may wish to consider for their patients. In their editorial, Drs. Papaleontiou and Capola reiterate that levothyroxine is frequently overprescribed in older adults, especially for mild thyroid dysfunction. Careful, patient-centered deprescribing, plus guidelines that clarify indications for initial prescribing, are essential to avoid unnecessary lifelong treatment.
Let's move on to the next research study, which is about primary prevention of atherosclerotic cardiovascular disease, which is projected to cost more than $1 trillion by 2035. Dr. Luby and colleagues assessed whether apolipoprotein B could be a better and more cost-effective target for intensifying lipid-lowering therapy used for primary prevention compared with the traditional LDL cholesterol or non-HDL cholesterol. The research used a computer simulation model to evaluate the cost-effectiveness of intensifying lipid-lowering therapy, modeling a cohort of 250,000 statin-eligible U.S. adults without atherosclerotic cardiovascular disease. The simulated population was drawn from real-world national survey data between 2005 and 2016 from NHANES. The research team compared 3 strategies for intensifying lipid-lowering treatment, each using a different goal based on LDL cholesterol, non-HDL cholesterol, or apolipoprotein B levels. The primary outcome was the incremental cost-effectiveness ratio. A apolipoprotein B goal was estimated to produce the most quality-adjusted life years and was highly cost-effective. The results of this modeling study support the use of apolipoprotein B as a cost-effective marker to guide primary prevention lipid-lowering therapy.
In their editorial, Dr. Pandya and Xiao discuss how using ApoB to guide statin intensification scored best for cost effectiveness, delivering the most QALYs for a reasonable incremental cost, compared with older targets like LDL-C or non-HDL-C. But they explain an important nuance. These results are strongest for older, higher-risk groups, and there's still debate about how well ApoB strategies work and how safe they are for lower risk or broader populations.
For the next article, let's turn to colonoscopies for cancer surveillance. Dr. Gupta and colleagues conducted a retrospective cohort study including nearly 92,000 U.S. veterans who had their last colonoscopy before age 75. Nearly 28% had adenomas identified at a prior colonoscopy. Researchers then followed these patients for 10 years, comparing those with and without prior adenoma. The authors found that at 10 years, the cumulative risk of colorectal cancer was slightly higher in the group with adenomas, 1.1% versus 0.7% in those without adenoma. Death from colorectal cancer occurred in 0.5% of patients in the adenoma group, compared with 0.4% in the non-adenoma group. However, non-cancer death far outweighed these risks, ranging from about 47 to 48% for both groups. The authors conclude that older adults may consider deprioritizing surveillance colonoscopy relative to other health concerns.
In their editorial, Dr. Wong and colleagues discussed that while colonoscopy is a powerful tool for preventing colorectal cancer, new evidence shows that for adults over 75, even those with a history of polyps, their risk of dying from something other than colorectal cancer exceeds the benefit of continued screening. The editorial voices concern about overusing colonoscopy in this age group, especially given the often overlooked impact of frailty and competing health risks, and calls for a more individualized, nuanced approach that weighs overall health, life expectancy, and the real chances of benefit. Preeti, let's talk about the latest research letters.
Sounds great, Linda. Manufactured sponsored drug coupons have helped reduce out-of-pocket costs for brand-name prescription drugs in the U.S., but policy changes like copay accumulators and formulary exclusions may be limiting their impact, especially when generics are available. Dr. Kang and colleagues analyzed a large sample of U.S. retail pharmacy claims from the IQVIA Formulary Impact Analyzer, covering from 2017 to 2024, and focusing on commercially insured patients using brand-name drugs without generic competition. They found that among 3.2 million patients, 18% used coupons in 2017, declining to 14% by 2024. For obesity drugs, coupon use dropped markedly from 55% to 2.5%, and for diabetes therapies from 21% to 8%. By contrast, coupon use for immunomodulators rose from 4% to 24%. Despite fewer manufacturer drug coupons, their value increased. Median amounts grew from $60 in 2017 to $90 in 2024, and patients' out-of-pocket costs stayed stable at about $10 per claim after using the coupon.
In another research letter, Dr. Wynn and colleagues investigated long-term opioid therapy for chronic pain using national data from the IQVIA Longitudinal Prescription Database from April 2012 to December 2023. They focused on episodes of opioid use lasting 90 days or more. Over 13 million patients contributed 16 million long-term opioid therapy episodes. 57% of the patients were female. Notably, the average age increased from 52.5 years in 2015 to 60.5 years in 2023. Older adults are now the biggest group exposed to long-term therapy and polypharmacy risks. The investigators report that long-term opioid therapy dropped by 24%. Medicare covered nearly half, 49% of these episodes, the largest share in 2023. The mean daily opioid dose declined from nearly 48 milligram equivalents to 39 milligram equivalents.
JAMA published 2 new viewpoints. In their viewpoint, Dr. Connercutt and colleagues tackled the critical issue of workflow blocking in clinical care. Their viewpoint explores how barriers beyond information blocking are shaping real-world usability of electronic health information for clinicians. They call for policy solutions that move past simple access to focus on meaningful integration in patient care. And Dr. Tu and colleagues write about the issue of skinny labels, an approved pathway enabling affordable generic drugs, and discuss whether recent court decisions threaten access by making it harder for generics to avoid patent infringement, with the Supreme Court's next move potentially reshaping timely access to affordable medicines.
Preeti, there's some great clinical content in JAMA. Dr. Choden and colleagues summarize the latest American College of Gastroenterology guideline updates for Crohn's disease care in adults. This JAMA clinical guideline synopsis reviews how clinicians can best diagnose, monitor, and treat this chronic inflammatory condition while minimizing risks and improving patient outcomes. And Dr. Shah and colleagues authored a JAMA review article that summarizes how symptoms and exam findings can help diagnose concussion in children after a plausible injury. Drawing on data from more than 7,000 studies, the authors explain that while no single sign seals that diagnosis, clues like mental fog, noise, or light sensitivity, and certain eye movement abnormalities sharply increase the odds. For more information, listen to the accompanying podcast with Dr. Shah and JAMA Associate Editor Dr. David Simel. Let's hear a clip.
I hope that the biggest takeaway from our study is that there are really some high-yield bedside assessments that most clinicians can integrate into their history and physical exam of an acutely injured child that can allow for concussion diagnosis with greater accuracy and confidence. And this will really allow patients to see trained specialists who can guide management decisions like returning to sport. We know that early clinical evaluation and timely management have been associated with improved recovery, including shorter symptom duration and earlier return to sport.
Don't miss the 3 new JAMA videos discussing balance and gait assessment, as well as cervical spine examination and vestibular ocular motor screening in suspected concussions. Finally, there's a new JAMA Plus AI Conversations podcast. JAMA Associate Editor Dr. Yulin Schwen sits down with Professor Feng to discuss how AI can help map disease trajectories. And as always, there's a lot happening in health news. The JAMA Medical News team has a summary podcast that publishes every Friday and gives our listeners insight into the latest medical news. You can subscribe at jamamedicalnews.com or click on the link in this episode's show notes.
Well, that's a wrap for this week's JAMA Editor Summary. Thanks, Preeti. And thanks to our listeners for tuning in to hear what's new at JAMA this week. These highlights were brought to you by Dr. Preeti Malani and me, Dr. Linda Brubaker. This episode was produced by Daniel Musisi and Dr. Krista Roberts at the JAMA Network. A link to this JAMA content can be found in this episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. And thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.